Cool. Then let's get started. So GI, gastrointestinal, GU, usually is genitourinary, but we'll just cover the urologic side of it. We don't really talk about male genitalia medical emergencies. We will have a whole chapter on female plumbing because obviously it's a little different. And a couple of different, let's say, jobs that come from that, okay? But GI, GU, let's get going. So starting up strong, like we usually do, we'll get into an intro, then A&P. So intro, abdominal pain, common complaint. You guys will see this one a lot. From the EMT basic perspective, I would, if I was you, have the mental capacity, that you should expect that you're gonna be running these calls. Okay, this is a call that often gets turfed to EMTs just because at the medic scope, there's not a lot we can do either. Now, I digress, there are opinions that can go one way or the other, but just be prepared. This is a call type you will see fairly frequently. Okay, now, another thing, when it comes to GI, you guys are probably not going to be able to determine what is the exact cause of what's going on. It's not like trauma where there's a high, I look at the vehicle, I look at what happened, and then 1 + 1 = 2, right? Nowadays, with GI, when it comes to medical, there can be a lot going on. It's the same thing as when we talked about with respiratory, right? Like, people can be sick, just because you can see that they're sick doesn't mean you know what they have, right? So it's kind of the same idea. However, you are gonna be able to, or you guys need to be able to identify, is this a life threat or not? So as the EMT, you do not need to determine the exact cause, and then you should be able to recognize life-threatening problems and act. We can always treat for shock. We can always be a little bit ahead of the game, okay, when it comes to treatment potentials. Questions on these at all? Okay, so A&P. The abdominal cavity contains our GI system, genital system, and urinary system. Both male and female do have some internal genitalia. Obviously, female is more primarily in the in the abdomen, and then made up of a combination of solid and hollow organs. So let's throw it back to shock. If a solid organ ruptures, what happens? It what? It bleeds, yeah. A hollow organ, if it ruptures, what does it do?
Spills its contents.
Yeah, it spills its contents. It leaks, right? So if our stomach, the actual stomach bursts, that's going to be like stomach acid floating around. If our urinary bladder bursts, there's urine floating around. So solid organs bleed, hollow organs leak. Which if we kind of extend this, solid organs bleed, what kind of shock are we worried about? Hypovolemic shock. If we're talking about a hollow organ rupture, what kind of shock are we worried about there? Septic, right? Infection. Now, a hollow organ rupture with that infection, it can take some time to develop, but it still will develop. Okay, so that's kind of back of the mind stuff. This is where we can think that far ahead. Okay, this is what I've shown up to. If it's this, I'm ready because I'll do this. If it's that, I'm ready because I'll do that. Okay, start putting them together. So, injury to solid organs can cause shock and bleeding. Breaching of hollow organ causes its contents to leak, therefore contaminating the abdominal cavity, like we just discussed. And then here's the layout. So on the left side, the solid organs, on the right side, the hollow organs. So liver, spleen, pancreas, kidneys being the big ones on the solid side, as well as ovaries in females. And then on the hollow side, stomach, gallbladder, ureter, large intestine, small intestine, urinary bladder, and females, the uterus as well. All of these are hollow organs, so just have the general understanding of where they are, okay? The big ones you'll definitely need to know when it comes to solid organs, liver and spleen, which one's on which side, okay? Can someone tell me in our abdominal cavity, where do the kidneys sit? In the back. What's the med term for in the back there?
Posterior.
Not posterior, it's close. Retroperitoneal. So posterior is referring to like the back, retroperitoneal is in the back of the cavity. A little different. Yeah, good job. Okay. So the GI system, responsible for our digestive process. However, digestion actually starts in the mouth, okay? Chewing. Chewing is the first step. Now there's chewing and then there's also our saliva that gets involved, but the act of chewing in a med term perspective is mastication, M-A-S-T-I-C, mastication. Okay, and then so that's gonna be the physical breakdown of food. And then in our saliva, we have enzymes as well. And these enzymes will start to break down our food at the chemical level. Okay, so we're doing a bit of both before we even swallow the food, before it starts entering the digestive system. Okay, now the stomach is the main digestive organ with gastric juices breaking down food. We have hydrochloric acid that lives inside of our stomach that is responsible for the breakdown of food. So that's another physical and chemical breakdown, okay? Now from there, this is where the liver and the gallbladder get a little bit involved, okay? So the liver assists in digestion, secretes bile, also aids in the digestion of fats, okay? That's why people who eat a lot of fatty foods tend to develop a thicker fat lining on that liver there. Okay, filters our toxic substances and then creates glucose stores. I would make a note of this. The liver creates glucose stores. Okay, those glucose stores are called glycogen. G-L-Y-C-O-G-E-N. Glycogen. Just hold on to that because it's going to come up in the next one, or excuse me, the next lecture today. And a lot of exams, a lot of benchmarks love to include glycogen as kind of a trick question, okay? Because it has to do with our blood sugar, and you'll see why in the next lecture today. And then we also have our gallbladder. Remember, our gallbladder lives underneath the liver. I always imagine it as the little fish under the sharks, right? But the gallbladder lives underneath, and that's where we store the excess bile, okay? This also starts to play a role when it comes to fatty foods, because a lot of times when we talk about cholecystitis or inflammation of the gallbladder, which we'll get to, it has to do with fatty foods, fatty content, because it's so closely tied to our liver, which breaks down fatty foods. Okay? Questions so far? Okay. So moving down, so from the stomach, the digestion started, we're moving forward to the small intestine. Now the small intestine is broken up into 3 parts. We'll go through each one individually. So the first one, duodenum, or the duodenum, however you want to pronounce it. I learned duodenum. I like that word better, so that's how I'm going to say it. Digestive juices from pancreas and liver mix at this point, okay? So we have those, for lack of a better term, chemical mixtures starting in that small intestine to further break down food at a chemical level, okay? This is where we start to break down all of the nutrition of the food so that we can start absorbing it, okay? So the pancreas will release amylase, bicarb, and insulin in response to the duodenum working. Okay, now we'll talk about insulin once again in the next chapter today, but this is a pretty big thing to recognize, okay? Amylase helps to break down foods once again at the chemical level. Bicarb is something that keeps our pH balance, okay? And then insulin, like I said, we'll talk about more, but it has to do with the sugar, right? We know that if we eat food, our blood sugar goes up. Well, the insulin is responsible for that, okay? Now, from the next section, the duodenum, we move to the jejunum, okay? Now, the jejunum does most of the heavy lifting when it comes to digestion, okay? Well, rather, absorbs most of the digestive product. Its job is not to break things down. Its job is to kind of be a sponge, okay, and grab all of the nutrition, all of the nutrients from the food we've eaten. Has anyone ever seen Semi-Pro before? When it gets punched in the jejunum and it makes them vomit? That's one way you will never forget if you know that movie, okay? If you haven't seen the movie, it's pretty funny if you like Will Ferrell. Okay, move forward. So from the duodenum to the jejunum, we end in the ileum, okay, the last section of the small intestine, with our small intestine being pretty long total, like something like 20-something feet in each person, okay? Now, the ileum absorbs nutrients that were not absorbed earlier. I kind of think of the ileum as if you've ever seen someone panning for gold, there's always that last section where they scrape the very last amount of gold out before they just throw the rocks back. That's how I imagine the ileum. The ileum's job is to pick up the remaining bits of nutrition so that our body can absorb them, okay? Now the ileum also reabsorbs a lot of the bile acids that have been secreted up until this point. Okay, reason being is that we just recycle a lot of that stuff in our body. Okay, we don't have to go and eat a bunch of acids, right, to replenish ourselves. So that's because of the ileum. Okay, so Absorbs bile acids so they can be returned to the liver for future use, as well as vitamin B12. Vitamin B12 helps with nerve cell and red blood cell production. So any excess B12 or any little bits of remaining B12 will also be reabsorbed and recycled back. Okay? Questions on the small intestine. So if we follow the track, right, we chew our food, we swallow. What's the name of the food tube that we swallow things down? Starts with an E. The esophagus, right? So we chew, swallow, goes down the esophagus. Once it's done with the esophagus, it lands in the stomach. Kind of does this little washing machine activity there, right? Breaks food down. From there, it's going to move to the small intestine, so duodenum, jejunum, ileum, and then we progress to the colon, okay, or the large intestine. Now, food that is not broken down will end up in the large intestine. Okay? This is where stool is formed. Stool, poop, right? So water is absorbed, stool formed there. We'll talk about what happens when portions of this don't work as well. We'll talk about potentially impacted as well. Okay. Now, things about the colon. Let's see. I'll just draw a picture. When it comes to the colon, I like you guys to know the shape, and it kind of helps kind of figure out how the body works to certain degrees. So when it comes to the shape of the colon, it is kind of a big old upside down U. Okay. So a little tail there. This is essentially, and that's our rectum right there. This is the colon, okay? So this is the ascending colon, so it's going up. This is what's known as our transverse colon, because it's going sideways, and then our descending colon, okay? So everything flows this direction, okay? This being the rectum, i.e. poop chute, right? So everything's leaving there. Couple of fun facts when it comes to digestion. If you ever notice that you're having a hard time digesting your food, or like you kind of just feel like it's sitting in you hard, lay on your left side. If you lay on your left side, gravity actually kind of helps the progression. It also helps with things like acid reflux. It's obviously not a fix, but it does help in a pinch if you're in the middle of the night and you notice that it's happening to you and you can't sleep or whatever. Okay. Questions on that at all? Okay. Now this last one, spleen, it's not really part of our digestive system per se, okay? It's just part of our abdominal contents. But the spleen is more of a filtration and then works closer with our lymphatic system. It's mostly up on there slide-wise just to say, hey, it's in there, but it doesn't do anything as far as digestion goes. Questions at all? Cool. Well, let's start talking about genitalia then. So the male reproductive system, testicles, epididymis, vasa deferentia, seminal prostate gland, and penis. So moving to the female side, ovaries, fallopian tubes, uterus, cervix, vagina. We will have plenty of up close and personal photos to look at and talk about later. Okay. Working our way through questions on genitalia at all. Okay. Working our way through the urinary system, right? So the urinary system, just by extension, we know urine is a waste product, right? So urinary system forms our urine, controls the discharge of waste materials from blood by kidneys, okay? So our kidneys will filter our blood, pull out all the excess stuff we don't need, and then that'll be partially excreted through the urine, okay? Now remember, our kidneys are solid organs, so what do they do if they rupture? They bleed, right? And then we have two kidneys, one on each side of our body, retroperitoneal in the back of the abdominal cavity here. Okay. Fun fact, when people get kidney transplants, because yes, you can live with only one kidney, but the person receiving the kidney, I always thought they pulled the old one out, chuck it in the bin, put the new one in. They actually don't do that. The third kidney, the new kidney, they just basically attach and they leave that third one kind of floating in there, which I always thought was kind of an interesting thing, but
You know why?
I don't. I would assume it has to do with things like bleeding as well as potentially hormone distribution for a while, because your kidneys play a giant role in keeping you alive. They're in the top 3 brain, heart, kidneys. So that's what I would assume, but I'm not entirely sure. So our ureters. So our kidneys, like the little bean looking deals that sit in the back, right? They have ureters, which join the kidneys to the bladder. So those are the rubber tubing, for lack of a better description, that goes down to the urinary bladder. And that's where we obviously drip the excess waste, okay? With the bladder being located behind the pubic symphysis, so behind that front bone of your pelvis. And then your bladder empties out urine outside the body through the urethra with the average person losing 1.5 to 2 liters of fluid a day from urine, okay? Yeah, questions on this at all?
Would anything over 2 liters be considered like excessive?
Is over 2 liters excessive? I would assume so, but I think it's kind of person to person, right? But yeah, 1.5 to 2 liters. I mean, that's a lot of urine though, over the course of a day, right? But yeah, I would assume depending on the size of the person would dictate that a little bit, but I would just say the average for a reason, right? Good. Okay, so here's our little description. This is obviously a male example. But our kidneys up at the top here filter the blood. We have our ureter tubing connecting the kidneys to the bladder, okay? Which is where they obviously are gonna drop off the urine. And then from there, the urinary bladder connects to the urethra. Both men and women have urethras, to which point urine will be exiting the body. I will say though, when it comes to the male example, we do have the prostate gland as well. That plays a pretty big role when it comes to, you ever know, I think I've talked about this before, but in the cartoons, there's the train lever that kind of shifts the tracks. Men obviously have 2 fluids that come out of the same exit there. So the prostate is essentially that train kind of track changer, okay? But then as we get older, or as males get older, that tends to become a problematic thing. When it comes to urinating, you will run calls on that very problem. Questions on urinary system at all? Okay. Well, let's start talking about patho then. Okay, so the abdominal cavity is lined by peritoneum. Okay, so peritoneum, think of it as the garbage bag that surrounds all of our organs. Okay, kind of like when we talked about in the lungs where we had the pleura. The peritoneum is the same or similar tissue types rather. But this is obviously in the abdomen, okay? This is where I told you, remember, parietal and visceral will come back, those 2 concepts. So parietal and visceral, remember our pleura, it says right there, but visceral is always organ side, parietal is always exterior body side, okay? So our parietal peritoneum lines the internal abdominal cavity, okay? The visceral peritoneum wraps around the organs. And then between the 2, we have interstitial fluid that allows for the gliding. We don't want the tissues to catch and then tear and tug on each other because obviously that's kind of a bad combination for being alive, okay? Now, we can get foreign bodies in our abdomen, or foreign material, not foreign body, foreign material such as blood, pus, or bile. These 3 things can irritate that peritoneum, okay? It's gonna irritate that tissue lining. Well, when things in our body get angry, they tend to get swollen, right? Itis. So peritonitis, usually caused by some sort of foreign material. That said, for you guys, if you see general abdominal pain and you're not sure what to call it, because I doubt you'll be really nailing everyone on the head, right, that you're gonna be able to guess, peritonitis is not a bad one if it's generalized. Usually what guides us towards diagnosis is specific locations of pain or discomfort, okay? Generalized peritonitis, those 2 go together really, really well, okay? Questions on that at all? All right. So what you guys need to be good at is the acute abdomen, okay? So sudden onset of abdominal pain. More so, it's not so much you gotta be good at identifying, you gotta be able to identify, is this acute abdomen now a life threat, okay? So often associated with severe and progressive problems. A lot of things in the abdomen, if they're not fixed, will progress into something worse, okay? Okay, so let's talk about some of them. So first one, peritonitis. We already talked about it. Inflammation of the peritoneum. Now this can cause ileus. Now before we get to ileus, let's talk about another concept, okay? So this first bullet right here, paralysis of muscular contractions. Does anyone remember what it's called when our intestines move stool forward? It's a big fancy P word. Anybody? It's peristalsis, okay? So peristalsis is the squeezing of our bowels forward, okay? So when ileus, so peritonitis, they've been so inflamed and irritated for so long that it's starting to progress into ileus, okay? When that point's reached, that peristalsis essentially stops, okay? Well, if we're not moving things forward, things like fecal material form gases, right? Obviously everyone farts, right? We all know that's the reality. But it forms gases, causes bloating and buildup because of that feces. Well, in our body, we've already discovered if things can't move forward the way they're supposed to, where do they go?
Back.
They go back. Well, when it comes to GI, we have an entrance and we have an exit. If the exit's closed, you can end up vomiting stool. Okay, that's what ileus is. It's progressed to the point that you are now emptying your bowel through emesis via vomiting. I've only ever had one case of this, not personally, obviously, but I had one patient who had ileus, and for your guys' knowledge, it was probably the worst thing I've ever smelled. Been in to the point where, like, when we were in the hospital pushing this patient by hospital rooms, nurses would open the door, gag, and then turn back around into their hospital room. It was atrocious. It was one of the worst things I've ever been around. So what I'd say is prepare yourselves mentally. If you hear about something like this going on, this can get pretty gnarly. On that same call, fire crew gave us a whole jar of Vicks Vapo Rub to rub on our face, on our masks, and none of it helped. So just fair warning, fair warning. Questions on peritonitis or ileus? Okay. The next one, diverticulitis. We'll talk about this a little bit more here in a second too, but diverticulitis, inflammation of small pockets at weak areas in the muscle walls. In particular, this is in that colon region, okay, or excuse me, the intestinal tract. Okay, when they say muscle walls, they're talking about intestinal muscle. Okay, well, inside of our intestines, we have these kind of little folds. The word cilia is what they remind me of, but it's not quite the correct description, okay? But here we have our intestine, okay? And then we have these little kind of flaps in there. And they're all over. I'm not going to draw all of them, but they're all up and down there, okay? Well, certain things with diverticulitis, so examples, things like seeds or like root vegetables that don't break down very easy, those little pieces can actually end up getting caught in these little folds here, okay? Well, when those pieces get caught, that's where we start to have inflammation of the area. And then if it gets so bad, it can actually progress to what we call formulation of a fistula, okay? Which we'll talk more about fistulas when we get to the urologic side here in a bit. But a fistula is essentially a fusion of two things, okay, of two organs. So essentially, they make their own separate pathway. They've worn a hole through that, okay? Well, at that point, if we start to have that fistula develop, we can actually have, because everything on this side of there is no longer being used, right? They're bypassing that. This tissue will all end up dying. Okay, so then we can start having a lot of issues. Things like bowel resections start to happen, so they got to cut pieces of their intestine out and restitch it together. All sorts of issues can arise from diverticulitis, which can also progress into a more chronic condition, diverticulosis. Okay, questions on this at all? Okay, and then the last one we'll talk about, a couple last ones, cholecystitis. Okay, so cholecystitis, inflammation of the gallbladder. Now, when it comes to cholecystitis, the 4 F's of the gallbladder start to show up. Okay, these 4 F's are the most likely demographics. Now, I'm just going to say it kind of bluntly because that's the easiest way to remember them. Okay, but the 4 F's when it comes to people having cholecystitis is females over 40 who are fat, who eat fatty foods. Those 4 things tend to show up with cholecystitis, okay? Now, on top of this is more so, you can have cholecystitis, which is gonna be uncomfortable, right? Liver under the right side there. It's gonna be uncomfortable for sure. But when we see flare-ups, just like any time in the body, if there's something that's struggling and we ask that portion to work harder, it's gonna do worse, right? Well, think about what the gallbladder does, right? It holds the excess bile. It helps deal with fat breakdown, like from the food we eat. So typically when we see this, it's the typical example is, oh, so-and-so just ate a double bacon cheeseburger, a really fatty food. Now they're having extreme right upper quadrant pain. It's usually gallbladder, okay? So those are the 4 F's of the gallbladder. like I said, it's not the most tactful thing, but it does help you remember. Okay, and then the last one, acute appendicitis. Can someone tell me what quadrant our appendix lives in? Yeah, well, other side. Yeah, lower right quadrant. Okay, so if we show up and they're complaining of lower right quadrant pain, you should almost immediately be thinking appendicitis or inflammation of the appendix. Okay, well, we'll come back to this. There's going to be more on appendicitis. Questions at all so far about patho? We're going to talk a little bit more about each of these. Just wanted to get it kind of, over the top looking at them. Okay, so abdominal pain. Now, when it comes to the pain, remember there's two types of nerves that supply our peritoneum. Okay, one set of them rather, the parietal peritoneum, is the same nerves that supplies the skin of the abdomen. Okay, well, if we think about the parietal layer, what side does that sit on? Organ side or abdominal wall side? What was it? For parietal?
No.
Parietal is wall side, yeah. Parietal peritoneum is going to be the exterior abdominal wall side. So those are supplied by the same nerves that supply our skin and our abdominal wall, which kind of makes sense, right? Versus the visceral peritoneum is supplied by the autonomic nervous system, okay? When it comes to like organs, they don't tend to feel pain so much, okay? But they do respond to those autonomic signals, right? Do we control autonomic nervous system? No. Right, so this is going to be all of the things we don't control, especially things like smooth muscle contraction, right, which our bowels are entirely smooth muscle. Okay. Questions on abdominal pain. It's pretty generalized. It's going to be a tough one to kind of work your way through from time to time. Okay, if there's no questions, I'm going to move on. Okay, so some causes of the acute abdomen. First one, ulcers. Protective, so with an ulcer, I'm sure some of you have heard this before, but essentially what it is, if we think about our stomach in particular, right? What is the liquid that our stomach holds? You can just generalize it. Huh? Hydrochloric acid, right? So it holds an acid in there. We obviously don't want that acid touching our organs all the time. That's problematic. So inside of that stomach, we have a really thick mucus lining. That mucus lining stops the acid from directly eating away at the stomach. Well, in an ulcer, more particularly a peptic ulcer, peptic is stomach, okay, but a peptic ulcer, that mucus is eroded away. And now you have the acid kind of coming up and just touching against the actual organ itself, which obviously is problematic because we don't want to digest our own organs. This will cause bleeding, okay? This will lead to bleeding. This can also lead to peritonitis. Well, let's see how much you guys have been studying pharm. What medication can we not give if they have gastric bleeding? Aspirin. Yeah, very good. This is one of the conditions. Do you have an ulcer? Or if you ask, do you have any recent internal bleeding? Oh, I had an ulcer that I just got wrapped up like last week. Maybe we don't give aspirin, okay? Start thinking it through. Questions on ulcers at all? Okay. The next one, gallstones. So gallstones may form and block its outlet. Okay. So our gallbladder, remember, it's our kind of the reservoir for excess bile from the liver there. It also has its own spouts to push bile out, obviously, into the stomach so we can use it. Well, if we have gallstones form and they kind of, I've seen them in person one time, and they're kind of like a lime green. They almost remind me of Play-Doh, but they're kind of like Play-Doh mixed with a cheese curd, would how I'd kind of describe those two things. But they live in that gallbladder. Well, that gallbladder can get so large that eventually, one, cholecystitis will start showing up, but two, we start having bile production problems and bile excretion problems. So let's look up some pictures. Oh, I gotta go to Google for the good ones. Yep. Yeah, yucky, yucky, yucky. So this is what it looks like. They look like internally, and then there's all sorts of examples of external gallstones.
Why'd you have to say they looked like cheese curds?
What?
Why'd you have to say they looked like cheese curds?
I don't know. Because I love ruining food. I know why. It's like one of my favorite things to do for you guys. Yeah. Yeah. Do you all kind of see cheese curds? Is that why you're upset about it? Yeah. You're welcome. It's true. I mean, yeah, it's fried cheese. I'll eat 90 of them if I have to. It doesn't matter. Okay. Questions on gallstones at all? Okay. Moving forward, pancreatitis. Okay, so pancreatitis, inflammation of the pancreas. If you guys have not started putting med term together at this point, itis, inflammation, with obviously the first word typically being the description, right? So pancreatitis, inflammation of the pancreas. Now, caused by several reasons. Obstructing gallstones is one. Alcohol abuse or other diseases of the pancreas, like pancreatic cancer as an example, that can cause some inflammation. In my experience, I mostly have seen this with alcohol abuse. Chronic alcoholics, liver and pancreas take a true hit, okay? Which I'll tell a story coming back to it. So signs and symptoms include pain in the upper left and right quadrants, okay? So it's not just the one side or the other, it's the whole top there, okay? Which our pancreas is also a retroperitoneal organ. So it sits more towards the back, okay? But signs and symptoms include the pain, nausea, vomiting, and abdominal distension. Remember, distension, it looks like bloating, so if they get super bloated looking, could be pancreatitis. And then sepsis or hemorrhaging can occur from that. But like I said, so going back, I've seen this one mostly with chronic alcoholics. A few years ago, my wife and I, we were on different schedules, but we were actually working out at the same station. So I was Saturday, Monday, she was Friday, Sunday. So she would give me a report in the morning. Well, one day I walked in, was like, how was the shift, yada, yada, yada. And she said, oh, by the way, there's a new guy around the corner, frequent flyer type, pancreatitis, he's chronic alcoholic, which pancreatitis also, pain will flare up after they drink, because once again, they're asking the organ to work harder when it's not doing well, okay? So these people will drink, and then once the time is kind of settled, they start having pretty severe pain. Well, so she's like, just be cautious. So sure enough, later that same day, we go back to him. And, I obviously had a little bit of a rundown on him, as well as our charts will show the history of where we've been, or not our charts, but our MDT will show you, oh, we've been to this address in the last 48 hours or whatever. So we show up, of course, we can see that on the MDT. I know the story. And when I talked to him, I was like, so what's going on? Oh, severe abdominal pain. Do you have pancreatitis? Yes, I do. Okay, how much did you drink? Well, I didn't drink anything. So, okay. So per my wife's report, the guy had drank, he had finished a fifth of vodka that night before I got there. So it was empty. He had no more booze in the house. She had confirmed this. When I walked up, it's like, hey, so then what's that? And there was half a bottle of vodka empty sitting right next to him on the front patio. And he's like, well, I don't know how I got there. Okay, I did drink. It's like, okay, thanks, full story, man, full circle. So, but I guess where I'm trying to take away with this is, one, don't be too judgmental, right? We all got our stuff. We've all made choices we're not proud of and we have to live the consequences of. But two, when it comes to pancreatitis, make sure you do your digging, okay? Be thorough. Don't be accusational, but be thorough, because it's going to guide your answers, okay? Questions on pancreatitis at all? Okay, moving forward. So appendicitis. So inflammation or infection of the appendix, okay, with nausea, vomiting, anorexia, fever, chills, rebound tenderness showing up. Okay, I'll come back to the rebound tenderness. But if we think about symptoms like anorexia, okay, so appendicitis, lower right quadrant, extreme pain. Well, if your stomach hurts, if your stomach's hurt, do you want to eat food necessarily? Not really, right? If you're having stomach pain, most people don't want to eat. So if this is a persistent problem, they've been dealing with it for a while, they don't want to eat, so they can drop a lot of weight, okay? Now, rebound tenderness, this is a test that we can do. I personally am not a big fan of it, just because it kind of confronts my own bioethics with how I would treat this, but it is a good confirming sign. You can use it. I'll just kind of describe what it is and let you decide if you want to or not. But appendicitis, so they have the inflammation of the lower right quadrant. They're in extreme pain anyway. So what rebound tenderness is you're going to press in on that right lower quadrant, and then you're going to take your hands away quickly. What's going to happen is that appendix is essentially going to slap the abdominal lining, and it's going to cause them to double over in extreme pain. It's confirmed, okay, this is probably appendicitis. Now, from a medicine or a more provider perspective, think about it this way. If we show up and someone's saying, I have extreme lower right quadrant pain, what's your first thought anyway? It's appendicitis, right? Is there anything that finding out, oh, that's for sure appendicitis is gonna do that's gonna change our treatment? Not really, okay? So that's where I leave it up to you guys. It's a good one for confirming, but if you're already thinking appendicitis, what's it gonna do other than cause more pain? Okay, so I leave that one up to you guys. Like I said, I'm not just not a big fan of it. And then with appendicitis as well. So like I said, extremely painful. If you're transporting a patient, potential appendicitis, lower right quadrant pain, and they're just doubled over in extreme pain, and then halfway through that transport, they go, well, I feel better. I actually feel good, the pain's gone. You should probably drive faster because what happened is that appendix just burst. And it's hard to feel pain for things that don't exist, right? If it's not there anymore, it's not gonna hurt, okay? Questions on appendicitis at all? Okay, so GI bleeding then, we'll move into the next one. So I'm gonna double check, okay. So GI bleeding within the GI tract, and this can be an acute or a chronic problem, right? So once again, acute is a right now problem, just started, chronic is over time. Now, with GI bleeding, there's two big things that you're gonna need to be able to identify, which first off, let's just kind of do some critical thinking. If we are bleeding inside of our abdomen, or bleeding inside of our organs, we'll even say, what do you think, what vital sign is gonna be affected pretty quickly that you might be able to see? What, say it again?
Blood in the urine or
No, not blood in the urine.
blood pressure.
Blood pressure is what I was looking for. What did you say? Oh, yeah, maybe blood in the stool, which we'll come back to. But blood pressure vital sign-wise, that's a big one, right? We can see that kind of changing because they obviously have blood going somewhere that's not supposed to be. Now, when it comes to where it is, so we have an upper and a lower GI. Okay, the way I think about it, if it's closer to the entrance, it's upper GI. If it's closer to the exit, it's lower GI. Okay, so basically anything from like, I would say duodenum up could be considered upper GI. Okay. Well, if someone's bleeding into their stomach, bleeding into that duodenum area, they're gonna start vomiting, right? Because it's closer to the entrance. That vomit is gonna be very specific in description. It's gonna look like coffee grounds. It's described as coffee ground emesis. I would write that down, stamp that to your forehead, remember that one. Okay, coffee ground emesis for upper GI bleeds. And it looks like coffee grounds mixed with blood, okay? What that means is that that blood is probably being digested, okay? Or has been digested, okay? Questions on that one at all? Coffee ground emesis, E-M-E-S-I-S, emesis. Now, oh yeah, go ahead.
So is it like the blood kind of clotting together because it's getting digested, or just like?
It's not even clotting, it's just getting like eaten alive essentially by the acids. Yeah. Yeah, so it literally looks like coffee grounds coming out. Now, if it's closer to the exit, we're gonna have melena, M-E-L-E-N-A, melena. Melena is described as dark, tarry stool. Dark, tarry stool. Which, you know, let's just kind of, once again, critical think here. If we show up and they say, yeah, I've been having blood in my stool. Okay, well, we would like, not like to, but we would like to take a look at it, right? Make sure we know what we're identifying. So where do you think we're gonna be looking potentially? Where do you think you gotta check? Huh? No, say it.
By the rectum?
Well, okay, where should we check not on the patient's body? Let's rephrase there. Huh?
Check the pants.
Check the pants, maybe. The toilet, that's what I was looking for. Check the toilet. So for you guys, when you're doing your assessments, if you're suspecting GI bleed, I would say it's not a bad idea to check the toilets in your oral scenario, okay? When I was in medic school, we had a scenario just like that. It was a bad GI bleed. I think it was like almost all of us failed because we didn't realize that our imagination land was broader than what we thought it was. At the end of it, I've had the same conversation with a lot of my former classmates. They'd be like, oh yeah, where did you not check? From the instructor asking us, where'd you not check? I don't know. Why didn't you check a bathroom? That's where the stool usually is. It's like, I don't know, right? So for your guys' scenarios, even if you're like, yeah, there's a pile of vomit over there, don't just say, yeah, gross, moving on. Maybe ask about it, right? This is where we can start getting hints, trying to figure out what's going on. I've had a few pretty gnarly GI bleeds. They've kind of presented a little bit differently. One of them I use a scenario, so I'm not going to tell you that. But another guy, I was working the ever elusive triple medic, which never really happens. There's 3 paramedics, meaning we were all rotating calls that day. But it was even better than that, because we had the one gal was like, I don't really want to run any calls today, so if you guys do all the call running, I'll write the charts. It's like, easy. So we show up to this, it was a nice house, North County, and they had that kind of bathroom that has its kind of separate little toilet room. So it was like the shower and sinks and then the toilet room on the side. And so I walk in, and there was like a dark black, purple, almost colored stuff everywhere, walls, everything. And so then at that point, both of my partners were like, we got to go move the rig. It's like, both of you, 2 people to drive the one vehicle? That's weird. But I got trapped in this room essentially with this guy, and it stunk, for record. And so talking to the patient, it was like, how long has it been going on? Well, it's been going on since the last, couple of hours. I was like, well, what do you think's going on? It's like, well, I ate some blueberry jam this morning. It's like, you think blueberry jam did this, right? Very much not the case. Ended up having a pretty gnarly GI bleed. Now, where we could confirm GI bleed was, once again, blood pressures. And I think our first systolic blood pressure on that guy was like 85. So just keep that in mind, right? If you see a lot of evidence of GI bleed, check your vitals, get moving. And then even more so, treat for shock. So lay supine, cover with a blanket, and give them oxygen. Questions on GI bleeds? Yeah.
Drinking a ton of beet juice create similar symptoms?
Of beet juice?
Yeah, that's what I've heard.
I mean, I wouldn't be surprised, because beet juice is like a kind of a dye. They use it as a dye. But I think you'd have to drink a lot of beet juice for the carnage this guy left. It was pretty impressive. Okay, moving forward. Esophagitis. If you guys aren't noticing, right, pretty trended once again. But the lining of the esophagus becomes inflamed by infections or acids from the stomach, okay, which is going to cause pain upon swallowing, heartburn, nausea, vomiting, and then sores in the mouth. Why do you think sores in the mouth start to show up?
Would there be stomach acids that would go up?
Yeah, they have heartburn to the point they have those fumes constantly in the back of their throat. Yeah, so esophagitis, inflammation of that esophagus, the connecting tube from our stomach to our mouth, right? So it starts to get inflamed. We start to have acid kind of backtracking up, and then we get that nausea, vomiting, and then sores in mouth, pain. It's gonna be pretty uncomfortable. Not a lot we can do for it, but we can help to maybe identify it. This would be, I would say, more of a history type thing. Okay, questions on esophagitis? Okay, so esophageal varices. I'll talk about them, then I'll tell you a story. It's not my story, it's a secondhand story, but I think it'll get the point across. So esophageal varices typically occur with alcoholics, okay? The reason being, once the liver starts to fail, blood doesn't progress forward as well, so it kind of backs everything up. Well, part of that backing up includes the vascular and capillary networks around our esophagus, okay? So once that backs up to such a point, there's so much back pressure, those capillary networks in the esophagus are going to start to leak, okay? Now, the signs, symptoms, fatigue, weight loss, jaundice, anorexia, edema, abdominal pain, all potential. Now, the biggest concern with these people is bleeding, okay? To the point these people will become like the little, what's that, Trevi fountain, in Italy there in Rome, and they have like the little cherub spitting the water out. They'll do that with blood, essentially. It'll be that much blood. So story, it was from my medic teacher. He was a medic down in Las Vegas for a few years, and he was telling us about this call that he ran where his partner went to intubate a patient who they couldn't tell, was in shock, couldn't figure out what was going on with him. Well, he missed his first tube, which typically when we miss the tube, you go in the esophagus. So not a big deal, it happens. What they ended up doing is you'll leave the tube there. That way, the tube's in one hole, you gotta go in the other one, right? 50-50 shot. So they left the tube there. As they were prepping the next one, my teacher said he heard like a gurgle sound, and then they looked and blood shot out of that ET tube with such force that it hit the ceiling of the ambulance, okay? So it will literally Trevi fountain blood out of their mouth. They'll be vomiting a lot of blood. okay? Which once again, that starts raising concerns for shock treatments, okay? This might be one that, you know, instead of laying them supine, if they're gonna be vomiting blood up the whole time, let's maybe avoid that. Let's lay them on their left side. That way we can have them catch the vomit and still give them shock treatments, okay? Now, when it comes to oxygenation of a patient like that, what device are we gonna use? We're worried about shock. It's tough, huh? It's kind of a back and forth. Because you're not wrong, right? You're doing this. I would agree with the nasal cannula, but can we go to 15 liters per minute on nasal cannula? No. But what happens if we put a non-rebreather on their face? It's gonna fill it with vomit. So at that case, get that nasal cannula on, get it to 6, okay? Some oxygen's better than none, and you can always titrate up if the vomiting stops, okay? Questions on varices at all? Cool. All right. We'll finish out these last couple slides and then we'll take a break and we'll get into the urinary system. Okay, the next one, Mallory-Weiss syndrome. This is actually more of a tear, typically seen in trauma, but can be induced medically. But what happens with Mallory-Weiss syndrome, I was taught Mallory-Weiss tear, is there's that junction point between our esophagus and our stomach, okay? Kind of a little fusion there. Well, usually trauma associated, but can be medically induced once again. They basically tear their esophagus off of their stomach. I actually had a former student who had one of these a few years back. He was a river guide. And he was saying, essentially it was one of the worst things he ever dealt with. They were on the river, they were doing like a 4-day camp river rafting trip. And he was like, I started getting this intense pain, started vomiting a little bit, didn't want to ruin the trip, but the vomiting only makes it worse and worse and worse. So he ended up getting life flighted out once he started vomiting up blood, okay? But he tore his stomach from his esophagus. So that's what Mallory-Weiss syndrome is, okay? The last one we'll talk about on this slide are questions on Mallory-Weiss at all.
Yeah, how does that happen?
So usually it's trauma. You can get it from weakened anatomy, like people who are bulimics, for example, they're vomiting all the time, self-induced vomiting. They can wear that thin, and then if they get to the point they vomit again, they can tear it. Yeah, but that's just an example. There's plenty of other ways. Okay, any other questions? Mallory-Weiss. Okay, so gastroenteritis. Gastrostomach, enterointestines, itis, inflammation of the stomach and intestines. Okay, now infection can be bacterial or viral. It can also be caused by non-infectious conditions, so things like fungi. Okay, with the primary symptom being diarrhea, this is a lower GI problem, closer to the exit rather than the entrance, so it's going to be coming out the exit. Okay. Now, we're not going to be able to tell for sure, oh, this is gastroenteritis. Maybe we can from diffuse pain across, but what we could maybe tell, based on a certain vital sign, is it's bacterial or viral. How do we tell the difference? What does a bacterial infection usually present as?
Isn't viral like you get really, really hot because your body's trying to fight it off, pretty much like fever?
Mm-hmm.
And then bacterial, not super sure about that.
So you flip-flopped it. So bacterial is typically a high fever. Remember, that's like our 102, 103, 104. Viral is typically lower grade fevers, okay? So like 100, 101, 101.5, those kind of things. Okay, good questions or good answers. So diverticulitis, we already talked about it. So fecal matter becomes caught in colon walls, causing inflammation and infection, okay? Fever, malaise, body aches, and chills, all potential. I got a little bit, unfortunately, got some firsthand experience with diverticulitis. My mother had it when I was in college. She actually, the first day of presentation was actually the day that I was driving back to school, which I lived a good 10 hours from here. So it was one of those like, I can't really hang around. I do got to go. There's not much I could do anyway at that point. So we ended up taking her to they took her to the ER, confirmed diverticulitis. And what she can't eat is things like peanuts or carrots or strawberries or raspberries, anything with those big seeds, because if they get caught, they cause intense pain. She's got a pretty decent pain tolerance and she was doubled over. So just keep that in mind. It's gonna be a pretty painful condition. Now, realistically, out in the field, you're not gonna know what it is, but you just might have a solid guess at it, okay? Questions on that at all? I know we've kind of talked about it. And then as far as symptoms go, for your guys' knowledge, malaise, this guy right here, malaise just means they generally feel bad. They just don't feel good, Okay, malaise. Stretch. Okay. Okay, now the last one we'll talk about is an important distinction. We talked all about GI bleeds. This is where we got to differentiate some things. So the next one is hemorrhoids. Okay, so hemorrhoids created by swelling and inflammation of blood vessels surrounding the rectum. So, lack of a better term, your butthole, right, starts to, the blood vessels start to basically become engorged to the point that they can have an aneurysm. Okay, that's not really an aneurysm, but that's just what it kind of is. So they have those vessels will expand to the point they start to bleed. Okay, so what's going to happen is that person's going to go to the bathroom, try to have a bowel movement, and they're going to have bright red blood in their toilet. To which point, you guys are going to be dispatched out to rectal bleeding, because it happens all the time, and you're going to have to make a choice. Is this hemorrhoids or is it GI bleeds? Difference is hemorrhoids not typically life-threatening. Okay, so if we're going to go back to it, what does a lower GI bleed present with? What's the symptom or sign? Melena. Yeah, melena, that dark tarry stool. Hemorrhoids, bright red blood. Okay, that's the difference. Now, not to say you couldn't have arterial bleeding that close to your rectum. I guess it's possible depending on your habits, I'll say, your activity choices, but more realistically, it's going to be hemorrhoids. Okay. And then for those of you who sit on your phone on the toilet for longer than 15 minutes at a time, you are a prime candidate for hemorrhoids, just fair warning, okay? Questions, comments, concerns on any of these things? Cool, well, let's take a 10-minute break. We'll come back at 9:12. Okay, so we talked all about GI. We're gonna start talking urologic now. So we talked about poop, let's talk about pee. Moving our way forward. So the urinary system. Okay, so we're going to work our way through with more so the condition stuff. We already kind of talked about the anatomy, okay, fairly similar structures, but working our way through. I want to check something. The cystitis, otherwise known as a bladder infection, okay, also commonly known as a UTI, okay, typically caused by bacterial infections. If they go untreated, they can progress. And typically with infections, if there's a pathway that, especially bacterial, it'll climb that pathway, right? So if we think about kidneys, ureters, urinary bladder, urethra, at the urethra entering, they get bacteria, climbs up to the bladder, climbs up through the urethra, can end up in the kidneys. So it will become a kidney infection if untreated, or can rather. And then what they're going to describe to you, this is a good symptom set. Reports of urgency and frequency of urination. I gotta go pee right now all the time, okay? The only thing is that they're often not gonna have enough urine to actually produce. It's a false sensation, okay? But a big one with UTI, do you guys remember we talked about it last week? AEIOU tips, right? The altered mental status mnemonic. Uremia, UTI. UTIs affect mentation pretty aggressively, okay? And then we used to see these a lot, more particularly in my experience with older females, just because their anatomy is so close together that it's easy for infection to spread, especially when it comes to people in assisted living facilities. Now, not every assisted living facility, but there are facilities where, this person, they're wearing Depends and they urinated themselves, but they haven't been checked on as routinely as they should. Now it's been an hour, hour and a half, 2 hours, and they've just been sitting in this urine. Well, that's a prime opportunity for that urine to create, or the bacteria in the urine to start backtracking up the urethra. Okay, and then another, as far as signs and symptoms go, or questions to ask, you can ask, how was your last, or what was your last urination like? Was it painful? Was it cloudy? Was there discoloration? Was there burning? That's usually a good indicator. Oh, there's been a lot of burning when I pee lately. Okay, well, that's going to guide me towards UTI until further notice. That could be a few other things, right? I.e., STDs, right? But for us, especially an older, read the room. If it's an older person, doesn't mean they can't have an STD, but more likely they're going to have a UTI. Okay? Questions on UTIs at all? All right. Moving on. So let's talk about the kidneys. So kidneys play a major role in maintaining homeostasis, Remember, homeostasis is the body's sense of balance, right? Everything is working the way it should, okay? Now, when the kidneys fail, uremia results, meaning they have a buildup of that excess urine, which now, since the kidneys are failing, is not being filtered out of the blood. Excess urine is not the right description. The kidneys are failing to filter the blood, so what's not being filtered out is just recirculating, recycling, okay? And then one thing that can show up as well are kidney stones, okay? Kidney stones can grow over time and cause blockages, usually in that ureter. Does anyone know anyone who's had a kidney stone before? I bet they looked really comfortable the whole time they were having it, huh? So for you, if you are someone who doesn't drink a lot of water, you are an exclusively carbonated drink type person, start drinking more water because kidney stones are in your future, which kidney stones can have a variety of fun shapes and sizes. So let's look at it. So renal calculi is how that's the med term for kidney stones. Okay. Calculi, like this guy. Yeah, so you can have all sorts of differing types of shapes and sizes of kidney stones, okay? So, and this is going from the ureters down to the bladder, and then usually it's gonna be out through the urethra. They will also use, I'm blanking what it's called in this exact second, but they'll use sound waves. One of the treatments is they'll put you in like a big bath of water essentially, and they'll shoot sound waves at your back to break up the kidney stone. So it makes it easier to excrete. Huh? Yeah, no, it's not ultrasonic.
Supersonic.
Yeah. It has like the sound, and everything. Yeah. What's going on in there? It's just kidney stones, no big deal. Yeah. I can't remember what it's called, but I'll look it up. But yeah, it's an interesting little thing. It works well. I know one EMT I used to work with, he got one while he was working at a golf tournament. And he has described it since as the most painful thing he's ever been a part of, to the point where he got fentanyl from a medic on scene, didn't even touch it. He got Dilaudid in the hospital, didn't even touch it. Okay, so, and Dilaudid is a pretty potent medication. So just keep that in mind. If you don't drink your soda or don't drink your water, you drink mostly soda, you're gonna get the stones and then you're not gonna have a good time. Okay, so moving forward with kidneys, I'm sure you guys have all heard of kidney failure to some degree. Okay, now we can split this into two different camps. There's the acute kidney failure and chronic kidney failure. Acute kidney failure, a sudden decrease in kidney function. Okay, so this is something where they haven't been pushing their water for extended periods of time. They haven't drank enough water, so their renal output is going down. Okay, now the nice thing about acute kidney failure, and that was just one example of many, the nice thing about acute kidney failure, is that it's reversible. Okay, if you're able to get a diagnosis and a treatment on it fairly quick, you can turn those tables back around and have fully functioning kidneys again. That said, if you do not receive treatment for acute kidney failure, it will progress into chronic kidney failure, which is a long, slow, painful death. Okay, it's irreversible. At that point, it's progressive, so it develops over months and years. These are the people who are also going to need a transplant. Eventually, that would be their fix. But more often than not, because I don't know if you guys are aware, but transplant lists are extensive and long and can take years to actually get the organ you signed up for. Okay, which the whole time you still got failing kidneys. So the more frequent one is dialysis. This is going to be the most common treatment, which we will talk about when it comes to kidney failure. For you guys who have done your ride-alongs, has anyone gone to a dialysis center yet? Okay. Well, if any of you do, let me know. We'll chat about it. But that's a pretty frequent one, especially if you end up while you're waiting for your 911 agency, or if you don't want to go 911, you'd rather work private. This is a very frequent interfacility transport type location. Okay, you deal with dialysis centers a whole lot. And there's a lot of ups and downs with dialysis as well. Okay, but we'll talk about that here in a bit. Okay, what dialysis actually is. Moving forward, I just want to see. Okay, yeah, so female reproductive organs, we're still in the abdomen, remember. So gynecologic problems are common, can cause acute abdominal pain. And then lower quadrant, especially in females, or particularly in females, may relate to the ovaries, fallopian tubes, or uterus. Now at this point, there's something I want you guys to write down. Any female of childbearing age who is complaining of abdominal pain, we are going to assume is pregnant until further notice. Okay, until you find out more information. Any female, childbearing age, with abdominal pain is going to be considered pregnant until we have more information. Reason being, things like ectopic pregnancies are missed fairly frequently, and they are a life threat to mother and obviously fetus. Okay? Yeah?
Just like to clarify, what's childbearing age?
Childbearing age, so north of puberty.
Okay.
At any point that they can have a kid. Yeah. With the youngest one, I mean, the youngest is a disgustingly low number, but teenage years, 13, 14, right? That's still part of the discussion. Yeah. We'll talk about ectopic pregnancies more on Wednesday. So, other organ systems that play a role in our abdomen. Okay, so we talked about aortic aneurysms. Now we're talking about the elusive AAA. Okay, abdominal aortic aneurysm. Remember, our aorta runs from our heart to about our pelvis. Okay, so AAA, difficult to detect, and then use extreme caution when assessing or detecting AAA. So first and foremost, what is a vital sign that we can check that might guide us towards an aneurysm? We'll see differences in something. Not pulse. Blood pressure. What in particular blood pressure? Not systolic. So, not high blood pressure either.
Wouldn't it be like super low at certain areas?
On either arm. We're going to take blood pressures and we're going to have, bingo, we're going to have differing blood pressures on either arm. High or low, it doesn't matter. If they're different, that's a problem, right? So differing blood pressures on either arm is going to be, we're suspecting aneurysm. Okay, now with the AAA as well, it produces what is called a pulsatile mass. Pulsatile mass. So when you feel into their abdomen, you'll feel something that shouldn't be there. Essentially, you'll feel something pressing up against you, but that thing pressing against you is going to have its own pulse. Well, what you're feeling is the aneurysm itself. So once we've palpated and you're like, oh, shoot, sorry, do you think that you should go and keep pushing on that bad boy? Probably not. Yeah. So pulsatile mass, differing blood pressures, abdominal pain. What is the descriptive term they'll probably say if we're worried about aneurysm? Remember, chest, for MI, it was chest pressure. Elephant on my chest. What do they say if it's an aneurysm? Tearing, ripping, shearing. Yeah, but it's abdomen this time. I've only ever had one time where I thought I felt the AAA. The hospital definitely did not agree with me or my partner, but it was a gal laying on the ground, pale, sweaty, pain, palpated, and I was like, oh, that feels weird. And so then I asked my partner, like, hey, will you feel this just so like I'm not going crazy? And she palpates and her eyes got big and she did like this number at me. I was like, cool, okay, I'm not crazy, we should go. Didn't get differing blood pressures, ended up not being one, but I don't know, it was a weird thing. It doesn't make sense what they called it as to me, but just keep that in mind, right? It's something, this is what we call a high acuity, low frequency situation. One second. So you don't see these very often. These sometimes are career calls, but the one time you do see it, you better be ready to deal with it, okay? Yeah.
So with differing blood pressure, how do you know which one's right? I heard like your left side is the one you want to like get your right side different than your left because your heart's on the left.
So how do we know which one's right? Honestly, I would just document both. Yeah, at a certain point, right? As long as like they look, one's close to normal, I would just document both, and then they'll understand the reasoning as to why. Yeah, good question. I haven't been asked that one before. Okay, hernias. Hernias are another thing we'll start to see when it comes to the abdomen. So what a hernia is, a protrusion of an organ or tissue through an opening into a body cavity where it does not belong. I told you guys a story about the diaphragmatic hernia patient I had where his bowel was basically in his chest cavity, right? But I'm sure some of you have heard of hernias. They are fairly non-life threatening. I know a lot of people, like weightlifters, will get them pretty frequently. Okay, may not always produce a noticeable mass or lump. Now what we're worried about is strangulation of that bowel. So essentially what happens you guys know when you put a rubber band around your finger turns really, really purple and that kind of discoloration? Well, what happens is that we have bowel now protruding through the abdominal wall typically. This is typically where it is. And what we're worried about is that those the abdominal muscles will get so tight they're pinching the organ, and now that organ is starting to turn purple and starting to die because there's no blood flow. You're cutting circulation off. A lot of times these are non-painful though. Like I said, the most common one are the inguinal hernias, which tend to be in the groin because you have 3 ligaments that run over each other like this. So that little gap here in the middle, a lot of times you'll have bowel go through. But you can have umbilical hernias. You can have them through the abdominal wall. When I was in high school, I had a buddy whose little brother got an umbilical hernia. He was like a year or 2 younger than us. And I went over to his house and his little brother's laying on the couch. He's like, you want to see something gross? It's like, absolutely I do. So he pushed and this hernia like came out of his belly button. And he's like, yeah, and then just shoved it back in. And he's like, it doesn't hurt, so it's a pretty fun thing to do. Which usually, that's a good sign, right? If they can reduce it and there's no pain, that's a good sign. If he had done that and it didn't go back in, or we started to see like red or blue color changes, okay, that's strangulation, that's problematic at that point. Yeah, he wasn't a smart boy, but sure was fun. Okay. So serious hernia signs, symptoms. Formerly reducible mass is no longer reducible. So for my buddy's brother, if he couldn't push that bad boy back in there anymore, that's no longer reducible. If there's pain at the site, that's problematic. If there's tenderness when it's palpated, that's problematic. Typically, like I said, not that painful. And then if we see red or blue discoloration, that means we are impacting blood supply. Okay, with blue obviously being no blood supply at all. Questions, comments, concerns? All right. So scene size up stuff, we'll go through this and we'll talk all about dialysis. Not a lot, pay attention to your surroundings, right? Mechanism of injury or nature of illness, we're talking medical, so nature of illness more than likely. ABC transport. History, once again, get your history. That's going to guide a lot of things. Okay. And then secondary, hands-on, which when we're palpating the abdomen, where do we start? If I have pain in the right lower quadrant, where do we start? What?
Away from it.
Away from it. Can you be particular?
Probably start in like the left upper.
I heard left upper. Do I have any? I like right upper better. Let's move clockwise with it, right? So right lower, let's move right upper, and then we'll end with pain. Okay, and the reason we always end with pain is because if you start with where it hurts, they're gonna say ow every time you touch them. That's just kind of the progression. They expect everything to hurt at that point. Okay, and remember, it's hand over hand, feeling quadrant over quadrant, okay? And don't do the thing, one of my biggest pet peeves when I was out in the field with new people, I say, hey, palpate that abdomen. They go, okay, does it hurt here? It's like, no, it doesn't hurt. Get in there, push, right? You gotta make sure. We're not in the business of causing pain, but we gotta double check some stuff. And if you're just gonna lightly tap them, that's not doing any good for anybody, okay? But that's my high horse, I'll step off of it. Vital signs, and then reassess every 5:15 as needed. Okay, now as far as medical care goes, this is another reason you guys tend to get these calls. Even at the medic scope, there's not a whole lot for us to do. Unless we're worried about bleeding and we need an IV to reestablish some circulation. For the most part, there's not much we can really even do. Okay, so take steps to provide comfort, lessen effects of shock. So treat for shock even when obvious signs are not apparent. Low flow oxygen may decrease nausea and anxiety. That's really kind of what we run. Which, by the way, yeah, oxygen is an antiemetic. Low doses of oxygen will keep you from vomiting. Okay, I don't want to say keep you from, because you will still vomit. You can still vomit, but it helps with the nausea. Same with smelling the alcohol prep pads, okay? That's a pro tip right there. If you ever feel nauseous, smell one of the alcohol pads. It'll nip that a little bit for you, make it manageable. Probably, I don't know what it is, I just know it works. Yeah, does a good job though. I always imagine it's because it gives you something else to think about, but I don't know, I know it works wonders. Okay, so let's talk about dialysis. So we're moving into kidney failure, once again, chronic kidney failure. So dialysis is the only definitive treatment for chronic kidney failure unless they get a replacement, right? Or a transplant, that's the word I'm looking for. So what dialysis is it essentially does the job of our kidneys, but outside of our body. Okay, so our kidneys filter our blood, right? So filter sodium, potassium, chloride, all the excess nitrates, all the yuck that we don't want. Okay, dialysis does the same thing. They pull your blood out, they filter it in the machine, you have another one on the other side, they reintroduce that same blood, okay? Now, if a patient misses dialysis, they can develop pulmonary edema. Now, here's another thing. For those of you who plan on progressing your scope to the point you can do IVs, anybody who has kidney failure, you gotta be really, really careful about how much fluid you give them, okay? Because once again, we've kind of touched on it a few times today. If an organ doesn't work very well, the last thing we want to do is make it work harder, okay? Well, what happens if you drink a bunch of water? What do you got to do 7 times a day? You got to pee, right? So people who have kidney failure, we don't want their kidneys working harder. So they're on actually such a limited restriction of water that even IVs are limited. I've heard that as low as 40 ounces a day for some people. Okay, which from a water intake, we should be taking about half your body weight in ounces. That's really, really low, okay? Now, some service transports, transport patients to and from dialysis, that's potential. But coming back here, because I can talk about this. If they miss dialysis, a lot of times too with dialysis, they pull off excess fluid. It's not uncommon for things like edema, peripheral edema, to show up really bad because of this, because they can't process their own fluids, so the fluids backlog and push into other places. But pulmonary edema, if they miss it, they can actually have that fluid backlog into their lungs. Okay, so that would be one. If we double check or we get done with dialysis, oh my goodness, we go into a patient who has dialysis and they miss dialysis and they're like, I have a hard time breathing. And you listen, what's the sound for fluid in the lungs?
Crackles.
Crackles. And we hear crackles, maybe that's a good confirming, right? Double check. There's also other things that'll happen. It's not uncommon for dialysis patients, either missed or just from dialysis, to go into cardiac arrhythmias because of their sodium levels. Typically, if they miss it, they go into what's called hyperkalemia, so they have too much potassium. Hyper, too much, kalemic. K is potassium on the periodic table. And if they go, usually if we pick them up right after dialysis, they're hyponatremic because they just took a bunch of their excess salt off and they maybe took too much. Okay, and that's a necessary ion for our body. Questions on this so far? Okay. So dialysis machine functions much like our normal kidneys, with the adverse effects of dialysis being hypotension, right? They took too much fluid off, dysrhythmias, too much sodium, muscle cramping, potassium taken off, nausea, vomiting potential, hemorrhaging from access site. We'll talk about that in here in a moment, okay? And then infection at the access site, which I want to just see something. Okay. I'll show you a picture of what these access sites look like, but they're called fistulas as well. Okay, a fistula is just, once again, the binding of two things, right? Well, they'll surgically create fistulas. These fistulas are a graft of an artery and a vein together. That way, when they pull blood, I said they have two. Typically, it's just off of the one. They can recycle and put everything back in from the same access site. Okay, which I'll show you surgical and then we'll talk about them. Now, as far as our care goes, when it comes to dialysis, ABCs, high flow oxygen, manage bleeding from the access site, typically pressure. If you have to, you can use a tourniquet, but you'll see why we typically don't want to here in a moment. Position the patient. So if they're having breathing problems, remember our breathers, we want them to sit up, let gravity help us, let gravity pull their lungs down rather than laying them flat, and now we have fluid spread across the whole thing, okay? And then transport promptly. Oh, and if supine if they're in shock, right? Kind of obvious. Now, I want to show you those fistulas, then we'll go through the review. But these fistulas can kind of make our job harder. Okay, so this is kind of what they look like. Let's see if I can find a more extreme one. Here's a way more extreme one, right? But you can see this on the arm, right? Or here's another good one. These are fistulated grafts. Okay, so veins and arteries together. Now, if we look at it, here's another picture. It's kind of what it looks like under the skin there, okay? But if we're looking at this, do you think we should take a blood pressure on this arm? No. Probably not, okay? These are expensive procedures done to obviously help the person through what they got to go through dialysis. We don't want to destroy it, Okay, it's not uncommon for these to start bleeding during dialysis as well. So we're going to try it with pressure, as much pressure as we possibly can, but it's arterial bleeding. Does that really, does pressure ever really help? No. Do you think we want to tourniquet these either? No. That's where I'm saying if we have to, you will. But if, try pressure first. I've only ever had to deal with one bleeding fistula, and it was arterial, and we couldn't get it to stop. But fortunately, where we were, the Meridian Hospital was right here. The dialysis center was in the same parking lot. So we drove less than 300 feet to the hospital. So we were fortunate in that case. They can add some difficulty. So check your protocol, make sure medical control is on the horn with this one as well. Okay? Questions on fistulas at all? Okay.